Hello everyone, welcome back to my channel. So this video is highly requested. I'll be showing you guys how to localize strokes, and then in another series of videos I'm going to show you each stroke type with its own questions. So let's get started. So I want you guys to imagine the big picture here in the pyramidal tract, that it starts out with neurons at a different part of the cerebral cortex according to the homunculus, the motor homunculus. So this part supplies the upper limb, this part supplies the face, this part supplies the lower limbs, etc. And then they condense in the internal capsule. And this is important to know because lesions in cortical branches of cerebral arteries affect only one part of the homunculus, so it causes monoplegia, as opposed to lesions affecting the internal capsule where all these fibers condense, and so it causes affection of the entire side of the body with hemiplegia and hemisensory loss, if I'm talking about the fibers of ascending to the somatosensory cortex. So the entire side of the body gets affected and not just the part of the cortical branch. That's the difference between cortical strokes and capsular strokes. Another part you need to understand, guys, is that the cortex is the site of higher brain functions. So whenever there is a higher brain function affected, you know this is a cortical branch. Let's say speech, for example, or let's say mood, or anything that has to do with higher brain functions rather than motor or sensory stuff, right? So let's say I have a cortical lesion here. It's only going to affect the neurons of the pyramidal tract in this region of the motor homunculus, and therefore it's going to be monoplegia, as in only upper limb or lower limb, right? Rather, plus high brain functions affection like speech, for example. Rather, if I'm talking about a capsular branch of a cerebral artery, because of this density, it's gonna be hemiplegia, right? Now, you gotta know, guys, that in addition to the corticospinal tract, we have something called the corticobulbar tract, which is upper motor neuron lesions, upper motor neuron fibers of the pyramidal tract going to the cranial nerve nuclei. Fortunately, most cranial nerves are bilaterally represented and will not be affected with a capsular lesion, except the hypoglossal nerve and the lower part of the facial nucleus. For this reason, capsular strokes are associated with inability to move muscles of the lower face, not the upper face. The upper face is good, but the lower face, because it's unilaterally represented. So when you have a hemiplegia with an upper motor neuron lesion of the facial nerve, you know this is a capsular stroke, okay? And that's how all cranial nerves, guys, are bilaterally represented, except the lower face and the hypoglossal nerve. All right. Now you gotta know, guys, that the brainstem is the site of cranial nerve nuclei. So if a cranial nerves are affected in a lower motor neuron fashion, you know that it must be a brainstem stroke. If there is hemiplegia, because the pyramidal tract goes through the brainstem, and any cranial nerve affection, you have to link it back to the site of the brainstem. So if it's cranial nerves 3 and 4, responsible for extraocular movements, that's a midbrain lesion. If it's 5 and 6, let's say facial sensation is affected, that's a pons lesion, pontine lesion. If any of the cranial nerves 9, 10, 11, and 12, responsible for pharyngeal muscle movement, so the patient presents with dysphagia, the patient presents with, let's say, choking, then you know that the medulla oblongata is affected. So these are lesions of the cranial nerves nuclei in a lower motor neuron lesion, and it's unlikely to be due to a capsular or cortical stroke because, like I said, these are bilaterally represented. So if there's any cranial nerve lesion other than the facial nerve, you have to think it could be a brainstem, and I'm going to be doing a video on that as well. So because this is the site of motor nerve nuclei, right? So hemiplegia plus cranial nerve affection, that's a brainstem stroke. Now let's go down a little into the spinal cord. When there's a spinal cord lesion, guys, it's most likely going to be paraplegia, unless the spinal cord lesion comes above C5, which is the origin of the brachial plexus. Then the upper limb will also be affected, and the patient will get quadriplegia. But usually spinal cord lesions are below C5, fortunately, and below after the brachial plexus has already given its outflow to the upper limbs, and therefore it's going to be a paraplegia where only the lower limbs are affected. But with spinal cord lesions, there is no affection of the cranial nerves, obviously, because they're up there in the brainstem, and there is only motor and sensory deficits, no affection of higher brain functions. So this is an overview, guys. I'm going to be tackling each type of stroke in a different video. I hope you liked this general picture of how to localize strokes in general, and then we're going to get into the details. All the best, guys.